Hello, good morning and good evening for all our audience in ICC. Today, we are so happy to have the invited speaker, Professor Susana Falardo, to come share her experience in the sleep medicines. Today is myself, Dr. P.Y. Cho, will co-moderate this topic with the prior and the junior together. Professor Susana Falardo is a distinguished expert in dental medicine, holding a Doctor of Dental Medicine and a European PhD in prophylaxis, pediatrics, and orthodontics. She also has master's degrees in myofunctional therapies and dental sleep medicines. Dr. Falardo holds prominent leadership roles in serving as the president of the scientific committee at AADSM and the president of the EADSM, an assistant professor and a researcher at the Catholic Medical School of Universidad Católica de Portuguesa. She is a leading figure in advancing dental sleep medicine through her extensive clinical, academic, and research contributions. Today's topic will be shared in myofunctional therapy on pediatric obstructive sleep apnea, as well as we invited three very invaluable panelists. So I will invite Prior to give the brief introduction of our panelist. Dr. Prior, please.
Okay. Hi everyone. I'm so happy to see all of you again. My name is Pierre. Today I will be the co-moderator with Dr. P.Y. Zhou and Dr. Chunyan Tu. And today is my truly honor to have the president of European Academies of Dental Medicine, Professor Susana Falardo, to give the presentation. And I would like to introduce three panelists who joined the sessions today. The first one is Associate Professor Nantika Sonsuwan. She is the distinguished expert in pediatric otolaryngology, currently serving in the departments of ENT at the Faculties of Medicine, Chiang Mai University, Thailand. With a robust commitment to advancing the field, she saw the positions of the deputy heads of the ENT department and actively engages in international affairs with the Royal College of ENT Head and Neck Surgeons of Thailand. And her leadership experience includes serving as the past president of the Asian Pediatric Otolaryngology Group and contributing to the Princess Surinthorn IT Foundation Craniofacial Center. And the second panelist, Dr. Nivi Kumar. She's a highly qualified dentist in dental medicine, boasting multiple board certifications include American Board of Dental Medicine, the American Board of Periodontology, with extensive training in cognitive behavioral therapy for insomnia. She has completely mastership and fellowship course in oral and facial pain, mandibular disorder, and both in adult and pediatric dental sleep medicine as well. And driven by her passion for sleep medicine, Dr. Kumar founded a sleep center in Bangalore, offering comprehensive care for sleep disorder. Additionally, as a certified periodontist and implantologist, she combined her expertise to address sleep-related breathing issue and craniofacial development in patients. And the third panelist, Renata Nami. She's the myofunctional therapist in private practice in South Carolina in the USA. And Renata is a registered dental hygienist with over 10 years of experience in the field and specializing in myofunctional therapy. And she has successfully established a practice that serves patients, providing expert care and guidance on airway health. Renata also earned her degrees from Armstrong Atlantic State University and Georgia Highland University, where she discovered her true calling for myofunctional therapy during a continuing education course in 2016. Inspired by Brazil's significant contribution to research in this field. And she drew from her personal experience as a former mouth breather, allowing her to empathize deeply with those affected by myofunctional disorder. And this personal connection fulfilled her commitment to improve airway-related health. And in 2021, Renata founded Airway Circle. It's a collaboration network of health professionals dedication to advancing dental and airway well-being, showing cases her leadership in the field and her dedication to holistic patient care. And maybe now it's time that for the Professor Susana presentations on the topics of myofunctional therapy for pediatric OSA. And welcome, Dr. Susana.
Thank you so much for the lovely introduction. I would like first to address my deep appreciation to Dr. Tair, Dr. Chu, and Dr. Junior too, for the lovely and pleasant invitation to be here and to be able to share some of the knowledge that I have with the subject myofunctional therapy. So let me just start to share. I think you all can see my screen. Just going to. So the topic today, it's myofunctional therapy for pediatric OSA, the do's and the don'ts. So I have no conflict of interest to declare to this presentation or to any other subject or presentation in the present or near future. So I was already lovely introduced, so I'm going to skip this slide. Through my presentation, before I focus on the main issue, which is myofunctional therapy, I will do some brief rounds on basic knowledge on craniofacial growth, also on snoring and OSA. And then I will go directly to the topic itself, myofunctional therapy, and I will end this presentation with a take-home message. So what we know so far from what is OSA, obstructive sleep apnea, is that it's a chronic disease with a high severity, also related with mortality and morbidity. It affects adults, but also in children presents a negative impact on cognitive behaviors, be it performance at school and cognitive functions as well. But when we think about OSA, we need to think, how are we so susceptible as a human beings to develop OSA? So I really like anthropology, and this took me to go and study what it happens. So what we know so far is that for the past 5 million years or so. So we had a lot of changes on our skeletal patterns that reveals also morphological changes, not only on the whole body, on the whole skeletal, but mainly also at the facial level. And in the light of the current knowledge, this evolution in this posture also contributes to the appearance of different partners of mandibular growth that has a direct impact on the upper airway, as we know. So bipod is main vertical posture of the human body may have caused the verticalization of the skull. But what we know is that during this evolution, it was not only the hard tissues who had some modification, also the soft tissues. So it means that the pharynx that nowadays present a floating iode bone, and the longer airway and the less direct air path for the passage of the air, favoring the appearance of the obstructive sleep apnea. So if you take a look on this image on this slide, we can see the difference that occurs. So we were mainly evolved from a B protrusive craniofacial wave to a B rectrusive. So we shortness the iode, the palate. We have the tongue backward into the aeropharynx, so we have less passage for the air. We lost the overlap between the epiglottis and the uvula. We stretch also the larynx in order to give space for the vocal cords, and we also advance the foramen upon in the base of the skull. But also, as I told and I was mentioned, it was not only the skeletal that had an impact, also the muscles. And we know, not going to take long because I think this is common knowledge, but if you look at the image, you can see by the arrows who are in different colors, all the direct muscles that contributes to keep the upper airway opening. And at the end of the road, it's the ones that with myofunctional therapy we need to address, and we need to practice them as much as we can in order to have a good balance and a good response for keeping the pharynx open. So again, yeah, we know that the iode bone and all of these muscles that contributes to the collapse of the upper airway, they are mainly at the retropalatal and the retrolingual regions, which is the area of intervention of dental sleep medicine, and what we do, so what we can achieve to resolve some of our cases. So we know that also the poor muscle response is also related with hypoxia, hypercapnia, and also that this negative pressure has been pointed out as one of the known anatomic phenotypes as a possible predictor of apnea. So if we look at this image, we can see here in the bottom of the slide the difference of the healthy upper airway and the between upper airway from OSA patients. So there's a slight difference, and of course the tongue and all the muscles involved in the tongue and on the palate arch has a responsible on this disorder. Looking at the tongue, what is interesting to see is how much the muscles interact by itself, but also how they are connected, not only with each other, but also with the mandible or the iode bone, some vertebrae, and also the shoulders and some of the claviculas itself. But it is very important to recall the main muscles of the tongue and what are the main activities that they induce in the tongue, and what are the muscle fibers and the type of the muscle fibers that we also have. And we need also to work when we are considering the myofunctional therapy itself. So we know that we have all these functions, and also the muscles, mainly they are classified according to the functions that they have in the tongue. And this is a major importance, because if you are addressing some myofunctional therapy to a patient, we need to know what kind of muscles do you need to work or to improve, and with that, what kind of exercise do you need to prescribe to your patient as well. So not only the muscles and the functions, but also know and be aware that they are also fibers. And this is just a friendly recall of type of the fibers, the red ones and the white ones, and then the subtypes of the white ones. And this is also very important, because when you are doing the exercise and you prescribe the exercise, you need to be aware that there are time to rest between the exercise, because there is fatigue of the muscles, and the response, well, it will be decreased if you continue without stopping, without these rest times. You will have fatigue on the muscles, and your response will be not the same as you wish to be. So there's a lot of evidence on on the involvement of the muscles and on the function of the muscles, especially the genial glossus, which is the main muscle in the tongue and the one that we need to work the most. And the difference between the fibers and the intensity of the fibers along this muscle, they are different from the tip of the tongue, from the mid side, the mid place of the tongue, and also for the base of the tongue itself. So also the exercise that you are going to prescribe to a patient, again, you have to have in consideration all of these type fibers, the position of the fibers, and what kind of exercise do you want to work. If you want to work more the tip of the tongue, that means the blade of the tongue, the body of the tongue, or if you want to work the base of the tongue, which is directly related to the palatal, the arcopalatal glossum. So the literature shows a lot of evidences of the involvement of the genial glossus and on the fibers, the fiber muscle types. And this particular interesting article also show that, but also concludes that the metabolic difference in the apneic and snoring are not observed in all upper airway muscles, and that histological difference you can have between the genial glossus and the upper muscles may implicate the pathophysiology of OSA. So again, we know that core muscle response is one of the phenotypes that are very well described in the literature, and I will go back to that in a few slides. Beside the muscles, we need to have, and when we are treating and when we are applying myofunctional therapy, we need to be aware of the fascias. And the fascias is like a kind of glue that sticks together all the muscles and that connects muscles between the bones and tendons and ligaments, and that allow us to do movements without falling apart. But it's very important because sometimes the response to the myofunctional therapy, it's not what we desire. So we need to look at these fascias, and we need to also do exercise and physiotherapy as well. So we know that the fascias have all these functions. It's related to muscle dysfunction, to the proprioception, which is very important, also to the pain perception of patients with a trigger point or some typical zone, also to the stiffness of the muscles and also to the weakness of the muscles. So it's major important also to know the anatomy of this area, because we know there are several layers, and especially on when we are thinking on the head, on the face, and on the neck. So we know that all these fascias have general functions and that they include and provides structural support. They protect the muscles and the organs and also reduce the friction and also transmit pain signals, which some of our patients also have oral facial pain, dysfunction, temporomandibular joint dysfunction related with some sleep breathing disorders as well. So again, we need to have in our mind all these layers of the cervical fascia in order for us to realize what are the type of exercise, what are the frequency of exercise that we want to prescribe to our patients, and well, in order to have a more personalized and precision. We are talking about precision medicine nowadays. So in order to have more personalized and individualized treatment plan for the patients. Also very important because nowadays all the world speaks about tongue tie, so we need also to keep on our mind that tongue tie is also part of the frontal facial of the whole body. So literally we are stick together between the tongues and the toes. So be also very aware when you are addressing the myofunctional therapy to this part of the body. Be aware and do a good evaluation of the tongue ties, but it's not this is not a procedure to do on a solo therapy. So you need to involve a multidisciplinary team between physiotherapists, chiropractors, osteopathics, pediatric dentistry, surgeries, myofunctional therapists. So we need also to have that in consideration. So because literally we are linked from the head to the toes. Going to this, continue to the frenulum and tongue ties. So does not matter what protocol do you use, so just use it, and you have to be sure that what you are going to do is the correct thing. So discuss that among your peers within the multidisciplinary team. But more or less, you have to be aware of the development of the tongue tie in the babies and in young children, in order for you to know what are exactly the good relation or the good position of the tongue tie and the bad position of the tongue tie, in order that you need to address any type of surgery. Again, just a friendly reminder that are two types of ties, so the anterior tie and the posterior tie. So this one, the posterior one, it's more difficult to evaluate, even though you need to put your fingers under the tongue when we are evaluating babies, like these photos. So this one is from my appointments. So yeah, you need to put your fingers inside the mouth, below the tongue, erase the tongue, and you can see if you have raised the floor of the mouth. So probably you have a posterior tie. But if you have doubts on the children or teenagers or even adults, if you have doubts, so my advice will be first start with some functional exercise and see if you have a stretch of the tongue tie. If you don't have, if the tongue continues in the same position, so you need to consider to have surgery. But be careful when you do that. So you need to establish a good protocol with, again, interdisciplinary performance between speech therapists that has to address myofunctional exercise. Then you need to perform the surgery, and then you need to continue again with the myofunctional therapy. So yeah, when you are looking for the ties, don't forget that you need also look for the lip ties, the lateral ones, and to see how are, and especially the middle, the lip ties, who because there are always compensatory muscle movements when we have situations like this one. And usually these babies, these children, they have a low lip mobility, and they have a lot of difficulties to breastfeeding or even artificial feeding as well. And of course, we also know that these compensatory muscles movements, they have a negative impact on the growth and on the stimulus of the maxillomandibular growth. So yeah, we need also to be very careful when we evaluate those in order to give the best treatment plan. Again, so this is not an evaluation to do it alone or a procedure to do it alone, but we need also to evaluate diction. So how is the speech of these children, if they already speak, if they have any alterations on the posture, especially the cervical vertebrae, and if they have already signs of mouth bleeding. So as I told you before, and I showed you already an anterior slide, it was one of the categories that you can use, but also this one, you can use this one, this neonatal screening test, or it was based on the Bristol protocol, but you have another ones. But be aware when you use it well, and do it in a multidisciplinarity. So when I'm talking on myofunctional therapy, I'm not talking on a new therapy. I'm talking on an old therapy, a therapy that has already, and fortunately, a lot of systematic reviews, meta-analysis in the literature. So it's very well scientific approved, and the literature speaks for itself. When you, for instance, with this article, you can see that myofunctional therapy was applied after lingual frenectomy in patients with tongue tie. So a total of 130 patients were affected by ankyloxia. So they had myofunctional therapy, and also global postural exercise were performed. And what we could see on this was that all of this therapy improved movements of the tongue, and could give more mobility of the oral tissues itself, and also on the conditions. Of course, that I'm talking about a therapy that we need to address for snoring and for OSA, and this is just a brief recall of what it is OSA, because we all know what it is at this time. But OSA, it's characterized, as you know, by a recurrent collapse of the pharyngeal airway during the sleep. So if you have a reduced respiratory flux, we are mention hypopneas, or if we have a complete session, we will have an apnea. And snoring does not matter if it is primary or secondary, is the most cases the culmination of a respiratory event, and it's associated with an arousal. So when we apply this definition to the children, we need to be aware, and according David Gazal, that I'm pretty sure that we know, that you all know him, that the pathophysiological mechanisms that are underlying pediatric obstructive sleep apnea can also be classified as narrow factors if we are only mention and if we only relate this to soft tissue and inflammation, soft tissue of the upper airway, like adenotonsillar hypertrophy, and of course obesity because of the fat pads of the lateral of the pharynx, and also the fat that we can also have on the base of the tongue. Of course, there are also other factors, collapsible factors. If we are then we think on some neuromuscular disease, and again, obesity that can impact you, inflammation of the upper airway itself. So understanding all these mechanisms, and I have to mention this classification and this slide on the study of Danny Eckert. So mainly we have two groups of phenotypes, the no anatomics and the anatomics one. So the anatomics, it's what we know so far. So it's everything that is connected with growth and skeletal development, and exactly what we address to. And the no anatomical are related to poor muscle response, so arousal threshold, and also loop gain. And what we know from the article and the studies from Danny Eckert is that 69% of patients have impairment in one or more non-anatomical traits. So again, if you think on the poor muscle response, how do we work that with exercise? So it's the main field of the myofunctional therapy itself, because when we look and we do the personalized treatments in order to have better outcomes, we can see that CPAPs fits all, but is that the solution? I don't think so, and I'm pretty sure that you all agree with me. So the prevalence, it's also again, and in the population, in the adults population, it's very frequent, prevalent between men and women, but also we know that, that there's an increase of the rate if you consider the adults females, so that's 3 times those rates for having OSA for menopause women, but also for children, that's a very high prevalence. 1 to 4% of children between the age of 2 to 8 olds can present also obstructive sleep apnea. And when we consider children, just for you to consider and be aware that for the classification, you only need to have one snoring episode, you only need to have one respiratory event in order to classify that. Also, because we know that the gold standard for diagnosed sleep exams are type 1 polysomnography, but because of all those difficult times around the world, It's very difficult for the majority of the diagnosed and for the majority of the exams being type 1. So there's also type 2, type 3, and type 4, but be aware that when you are using in children, the saturations, they do recover very quickly, and some of these home sleep apnea tests and home sleep tests, they don't have specificity and sensibility to detect oxygen desaturation. So you need to do a capnography where you are doing also the polysomnography for diagnosing respiratory disorders. And what about the classification? Also, there's difference. So children are not small adults, so they have different classifications. I'm sure that you all know this, but just in a quick remind, we only need to register 1 event per hour in order to have a classification of apnea-hypopnea index. And we have 3 categories: mild, moderate, and severe. The same as adult, but the number of events are lower, so we need also to be aware of that. So again, risk factors, and it goes the same for adults and children. But even though I have to mention that obesity is nowadays the main epidemiological risk factors, and of course, body mass index. But be aware that if you could have a super fit women or men with a very high body mass index, and that does not mean that it's a risk factor. But even though it's what it is in the literature, so we need to mention that, but just be carefully when you are using this algorithm in order to evaluate. So neck circumference also, and I would add here the abdominal circumferences as well. And be in mind that obesity, it's not only for adults, it's also, unfortunately, for children nowadays. Also habits, smoking habits, alcohol, beverage, late heavy meals, sedatives, and again, increasing the weight and obesity. So it's not only typical for adults, but also children. Plus, in children, we need to also evaluate, and here we need to work together with ENTs, of course, in order to evaluate the adenoids and the tonsils, because hypertrophy of these inflammatory tissues is one of the major risk factors for obstructive sleep apnea. And we also know that they will have an impact on the mouth breathing pattern, the skeletal facial growth. But of course, there's a genetic pattern that we need to be aware, and again, the weight and obesity. And now going through the myofunctionally, which is the main goal of this lecture. So it's not, as I said in the beginning, it's not a novel thing. So I'm talking about therapy that has more than 100 years, and it was developed the first time and described in 1912 by Leisure, that introduced this term of myofunctional therapy in order and with the objective to prevent and treat malocclusion through re-education. So again, we are still talking about this, how we use exercise in order to re-educate our patients and the patterns and the breathing patterns and so on. And it continues on the 17th and the 18th, and of course in the 21st century with Aline Braga, Sterbiancini, Caterina Camacho, and also Hanato is also here. So the lovely work of these 4 ladies and great friends from Brazil, they have been applying all these myofunctional and show how this can have good outcomes in the treatment of the snoring and apnea as well. So when I'm talking on myofunctional therapy, I'm talking what is the main goal. So the main goal is that these exercises, this therapy seeks to equalize through isometric and isotonic exercise the muscle tonus of the tongue, of the soft palate, and overall of the face, which is exactly the objective and the intervention that are here related and involve the structures also and snoring, and it is the objective intervention of the myofunctional therapy. I have to mention this because it's such a brilliant article, and this was published and released during the World Sleep Society meeting in Rio de Janeiro, which positioned the speech therapist and the importance of myofunctional therapy in the multidisciplinary approach to not OSA, pediatric and adults, of course, but we cannot disregard to have these professionals with us, and we cannot disregard to evaluate our patients from the muscle point of view and from the function point of view of this disorder. So systematic reviews, we have it, confirming the importance of this exercise and how they can have an impact on the treatment as a solo or as a combined treatment to the pediatric obstructive sleep apnea. And this is one of the articles that it's exactly a systematic review that shows that our myofunctional therapy can improve the function and the morphology of the craniofacial surface in children with OSA, and also could also happen that could also increase and improve the craniofacial growth as well, and the function of these children. Another good article that relates myofunctional therapy after the surgery of adenoids and tonsils and the impact that this has on the apnea-hypopnea index shows that the 32% of the children that were submitted to myofunctional therapy after surgery, they had lowered the oxygen, the saturation index, and that they eliminates the snoring as well. And again, a systematic review from Brazil based on 124 articles shows that applying myofunctional therapy, in this case in adults, could decrease the apnea-hypopnea index, can improve the oxygen saturation index, and improve the daytime somnolence and snoring, which we know so far are two aspects to have adherence to the treatment. So again, continue from a group from Italy that did this publication based on the evaluation of 54 children. Again, they had a huge impact, positive impact, improving the oral breathing, the labial muscle tone, the tongue posture, and the oxygen, the saturation index. So I think this is very important to consider myofunctional therapy as therapy to include as a solo or a combined therapy because the muscles need to be balanced across the therapies that we prescribe to our patients. And another group, another great article that relates myofunctional therapy and combined with the myofacial release of fascia. We are now talking with the combined therapy, and we can see that doing the both therapies for muscles and fascias, we also had reduction of the daytime sleepiness, improving of the snoring index, and we had a better oxygen saturation index, but also we improved the time below the 90%, which was really, really great to identify. And continue. So again and again, so the literature shows that myofunctional therapy has efficacy in reducing snoring, reducing the apnea-hypopnea index, daytime sleepiness, improving oxygen saturations, and of course, sleep quality. It's what we want for our patients. And directly addressing myofunctional therapy to these patients, what we can see is that we could reposition the tongue, improve nasal breathing, increase muscle tones, not only in pediatric, but also in adults. So, and of course, it could be a therapy, a combined therapy with orthodontic treatment, but also it could be a combined therapy to help adherence on other kind of therapies, like for instance, CPAP. What I do, what I share, it's my the guidelines and what I do on my appointments. So I work together with a speech therapist. So we do the evaluation together. I would say I will do 50% of this questionnaire that I'm going to share with you, and then she will do it again on her appointment, because otherwise we will have appointments of evaluations too long, and the collaboration of children, it's not very good. But well, we go through the treatments that these children had done before. We go through the pregnancy, the diseases, the food, how was it the food, how was it the changed from soft food for solid food. We going for parafunctional habits evaluation, also the speech and the psychomotricity development, social factors. It's very important also to know how is school adaptation, the relation with the professor and the colleagues. And of course, we are very observative during the first appointment, because we do like to watch the parents' attitude, even in the waiting room when they are waiting for the appointment, and then the behavior of the child, if she is very participative on the appointment or not. So we are always checking all these slight aspects. I like to use this questionnaire. This is not a validated questionnaire, but it's something that I developed along the time. It helps me to know the behavior and how is the activities that patients do. So I actually do three times of evaluation. So the time that they go to bed, the time that they go to sleep, and the time that they get up. And I ask simple things to the parents, and this helps us a lot to understand how is the how it works, that family. So what they do to their child, how is the daily life of these children, and it helps us also to address if needed, because all the ways we have been facing that sleep hygiene rules and improve sleep hygiene rules as well. So the observation continues. So it's a long observation. So I go for also intraoral observation. I observe the lips, the tongue. So I will do also again the tongue tie score, the palate. Of course, I will watch and score Malampati, Brodsky. I have amygdalas. I'm going to look the cheeks and the internal mucosa in order to look for bite marks. Perhaps we could have some signs of bruxism, which is very important also to evaluate the relationship between the maxillary and the mandible, and also if we have or not any temporomandibular joint sounds or deviation or other type of dysfunction. It's also very important to evaluate the oral health, general oral health, periodontal, teeth conditions, or hygiene also. And we do a very slight evaluation of the nasal conditions. Because of our x-rays, we are able to see if there is any septum deviation, how are the turbinates, and if we have adenoids, or how are the nostrils, if they are symmetry or not, and if we have a good breathing nose, if we have a permeability in order to better address, if necessary, to the ENTs. And respiratory function as well. It's also connected with the nose, but we also check if there is a preference for nasal or mouth breather. And we also see how this patient breathes. If there is a diaphragma or abdominal effort, and we usually ask parents, we don't know how to ask, so we ask them to do a little record during the sleep of their children in order for us to help them to evaluate this type of position, breathing, of course. So this is a long evaluation, but I think as much as you can know on the first appointment, it helped you then after to establish a good treatment plan. So posture, it's very important to see and to observe how do these children posture, how do they put their feet, the legs, the shoulders, and the head, if there is a kyphosis or a lordosis then, so you can evaluate the needed and the involvement of other also professionals like physiotherapists, which are sometimes very needed and important also. The solid food swallowing, so we do a small video records during that. So usually we ask the children on the second one for evaluation of the functions, masticatory function, swallow function. We ask like little foods or some type of food that they like it in order for us to see how they catch the food, how they chewing the food, and how do they swallow. And also for the liquids, we also ask and we use straws in order to evaluate if they have strengths in the lips, which side they prefer to use the straw in order to drink the liquids, and how are the suction movements, if they are correct or not, or if they use compensated movements of the head or the facial mimic to help them to swallow. Speech articulation, so also we do evaluate, of course it's a speech therapist area, so we do some repetitive exercise in order also to catch if there is any alteration. I like to use this evaluation. It's more direct when they are not so young, when they are not babies. It's very good to evaluate and to see if it is, and according to this classification, if I have a normal, a mild, moderate, severe tie, it helps me a lot, and I like this evaluation. So for Malampati, I'm sure that we all know this, and for Brodsky, I'm also sure that we also know what is this. For the blood cell test, I use, well, just a regular mirror. This is not a validated instrument, but it's objectively, and for the moment, it helps you to realize if you have a good permeability or not, and if the nostrils work on the symmetric way. So it's simple, you can use it, but again, it's not validated. Or you can use your finger and in order to feel the flux to evaluate if there is any permeability of the nose, of course. So when I'm prescribing the exercise, I always have in consideration 3 basic rules. First one, the awareness of the nose. Second, the proprioception of the nose. And third, the verification of the nasal airflow. And 3 basic exercises before I starting the myofunctional therapy. I always recommend first circular massage on both sides of the nose. A good technique of blow by the nose in order to have a cleaning nose, and then we start performing isometric exercise with some kind of resistance of the lips and on the tongues and the cheeks, and again massages with circular movements in order to start the exercise per se. Well, there are some limitations. In every therapy, we have limitations. In some, we have contraindications. Here, we have limitations. It's not a contraindication to myofunctional therapy, but if you, according to the age of your patient, it could be hard to have adherence to your exercise if it is a very young patient. If the family does not have any level of cooperation, it also be a limitation, and also the motivation of this patient in order to perform the exercise. We need to be aware there also are limitations if we consider some dental skeletal disharmonies like palatal fissure, neuromuscular tunnel syndrome. So it's a limitation, it's not contraindication. You can do this, but be aware it's very hard conditions that you need to work in different ways. Also for cognitive and intellectual disorders and parafunction habits like thumb sucking or pacifiers, so you need also to be aware that you first need to stop this habit or help the child stop this habit. And it will be a limited exercise for these children. And also for the respiratory chronic disease, so be aware of that. So there's some limitations on that. It's hard sometimes for patients to perform all the exercise, so we need to know very well the exercise. You need to know very well the anatomy in order to prescribe the best therapy for the patients. So the rules that we use in our team for basic rules, so practice the exercise always at the same time, perform the exercise in front of a mirror, and in case of children, these exercise should be, they should be do the exercise with parents' help, and clean and wash the nose before performing the exercise, of course. So there's a lot of exercise. We do the exercise according, again, of the need. We need to know, again, the anatomy. We need to know the muscles and the function of the muscles in order to prescribe the best exercise and motivate these patients in order to have the best outcomes that we know. So for the inspiratory, expiratory, and the frequency, this is like going more or less like going to the gym. So you have to do, when you go to the gym, you have to do 3 times per 10 repetitions. So it's more or less the same. Our experience says that if we don't change the exercise, we could continue to work the same group of muscles, but we need to change every week the exercise, because otherwise we will lose the adherence of patients. If he's a child, he will lost the focus. He will not be focused on, and he will not have adherence, on the exercise. So you need to change every week at least. You need to change the exercise. So if you do this type of exercise, blowing exercise, you are working mainly the buccinators, the lips, and the diaphragm respiratory movement. So you need to know very well, like I said before, not only the anatomy of the muscles, but also the function of the muscles. This type of exercise, tongue thrust exercise, are exercise that mainly works the gyneoglossus. So and you have a lot of exercise that you can do. It's the patients usually, if they are more adults, they say that they feel silly to do this side, but children, they love to do this because it's what we as a parent say, don't put your tongue outside of the mouth. So now they have a prescription to do that. But even though you need to know that according to the movements that you are doing and the exercise that you are doing, if you swept the palate, for instance, with the tongue, you are working the genioglossus and the epiglossus. If you push the tongue against the palatal, you are working the suprayoides. If you are lower the back of the tongue, so you are working the epiglossus and the suprayoides again. So you need to know also. There's, as I said, different exercise to work the same group of muscles. For instance, if you use a tongue pressure like it is in the image, you can work the buccinators, or you can work the lip, the muscles and the lips using the pressure between the lips. For the palate, if your patient likes to think, to sing, this is the best exercise. So usually I do recommend this for adults, or if child has a karaoke device at home. So it's a very good exercise also. I don't know if the parents will love it, but yeah, it's a good exercise, or the neighbors if he does a lot of noise. But it's a good exercise for children, also for adults to work, because it allows us to work the tensor palatini, the levator palatini, the uvula, the palatoglossus, and all the palatoglossus arch. So we are talking about upper airway, so it improves a lot. For tools, we have the sensibility to know the possibilities and the economic possibilities of our patients. So in this image, so the instruments that are in the blue pockets, they are, I would say, the fancy ones, and the other are the domestic ones. So you can buy those in supermarkets or drugstores, and this could help you to work the tongue and do the exercise for the tongue. And then for exercise to blow, there's a lot of things that you can buy in every store. So, and the kids love it to work on those. And it goes from simple straws to more complex tools and that they can use. This one, for instance, is one of the professionals that you can use, and you can work the respiratory and also the inspiratory, expiratory movements and the lips with this kind of exercise. And for the masticatory muscles, which is very important, the masseter and the temporalis, you can use these silicone rubber gums that you can easily buy in the stores that sells myofunctional therapy tools. Or these ones, they are super cool nowadays here in Portugal. All the young kids like to use them because it's super fashion, particularly the ones that are going to the beach to do surf. So they love these times, but it's also this type of tools and necklace. And this can provide oral stimulation. They can do the exercise, the mouth muscles, they can build oral tone, and they can practice the biting, chewing skills as well. So, and it's also good to decrease the stress levels if we have signs of bruxism as well. And for the lips, so again, a lot of tools, more professional, less professional, but you can use one of those. And using this, you are going to increase the muscle tones of the lips, but you also are going to work the risorius, the zygomatic, and the buccinator, which is muscles that we also need to work with. So nowadays, I know that there are a lot of apps for mobiles, but on a simple way, I used to call this the Mastic app, which is a book guide where we usually draw all the exercise. And this is a motivational tool, of course, drawing the exercise helps parents, also helps children. It helps also to personalize the exercise. But if you have an app like this one, it was developed here for Portugal, so it's only in Portuguese. Children can address the app, they can do the exercise, and then according to the frequency of the exercise, they receive a score, and they are going to increase the difficulty of the exercise, and they can work the cheeks, the lips, the tongue, and then they can see the results. But for adults, I have to mention great work from a great group of friends here in Spain, near me. So Carlos O'Connor Rayner, he is a Yanti, and for the past years, he has developed an app who can improve by myofunctional therapy, can improve the muscle tonus of the tongue, and with very good results. The app it calls hair raging, so it's validated. And with that exercise, you can see by the research of Carlos group that you have improvements on the apnea index before the exercise and after 3 months of performing the exercise, and they evaluate all the tonus of the muscles with the IOP. So it's very well done, the research. And I have to mention myotape because now it's also fashionable. So we see a lot of, I would say silly things on the internet, people using myotape, influencers advising myotape, but we also need to know that, yes, there is an article. Patrick McCone published the article also with Carlos, but we need to know that we need to have very good nose breathing. This is not to use all night long, even though in some cases they're recommended, but we need to be aware that we need to breathe. So it's only for, I would say, a part-time use. I want to share a clinical case with you. So this is a pediatric case. It was a pediatric case recommended by an orthodontic friend who asked me to evaluate the sleep of this kid. It was, all the photos was performed during COVID pandemic. So this kid, he had a crossbite, but it was not a skeletal crossbite. It was a functional crossbite. So he developed a mandible deviation. He had some facial asymmetry. He had this sperm function habit to bite the nails and also the fingers. he used to draw, and it was good because I asked the mother how was his behavior, and of course she said to me, "Oh, he's behaved very well, but if you could see all the plastic protection that he had, he wrapped that all." So, and suddenly he was at my desk drawing my notebook. It was okay because I could see the posture of this kid was so wrong because he had the mouth opening with the tongue out, and he was drawing almost lie down on the notebook. He could not move the tongue, so that was the movements when I asked him to move the tongue. But when I drew the manipulation of the mandible, I suddenly correct the crossbite, so it was a functional crossbite, even though he needed orthodontic treatment. But my focus here was only to show you how it works as a solo first therapy, myofunctional therapy, because we did the polysomnography, we did a type 1 polysomnography. So we could see that it was a mild apnea index because he scores 1.9 respiratory events per hour. The snoring was not so loud. We have also some lip movements, but it was mild movements. But even though we start myofunctional therapy, we work the bite, so it was no longer crossbite, even though he continues to need orthodontic treatment as well. So we did between the last slide and this one, we took 9 months, 10 months of exercises. And we did again a polysomnography. And as you can see, we had almost 2 events per hour, and now we have 0.9 events per hour, 0 obstructive respiratory events. We improve a lot of the oxygen desaturation index and also the positional respiratory events. Also, we had a great improvement of that. We also improve the parafunctional habit that he has to bite nails, so he's no longer had that on that, and the behavior was very, very good. So my take-home message to share with you now is that I do consider myofunctional therapy on rehabilitation of both pediatric and adult snoring and nausea. I think it's fundamental for muscle reeducation, tonus recovering of the upper airway, and balance of the orofacial neuromuscular structures. As in coordination with interceptive orthodontic or as a solo therapy, myofunctional therapy improves mastication, swallow, and breathing, indirectly contributes for a better quality of life, and it should be part of a multidisciplinary treatment approach for snoring and nausea for both pediatric and adults. So thank you so much for your attention. Here you have my email if you want to contact me in the future. So I will be pleased to answer you. Thank you.
Thank you so much, Professor Falardo, for the amazing lecture, and thank you for the very detailed and very in-depth presentation. So at this time, I'd like to invite our panelists for some panel discussion. And the first panelist I would like to invite is Professor Susana. So, Professor. Actually, let's go to Professor Kumar then. Professor Susana, can you hear?
Susan, yeah.
Yes.
Okay. Thank you, Professor Susana, for very comprehensive and informative lecture. Per, could you share my slide? I would like to add some more my point of view from ENT perspective. From share, could you share my slide? Okay, yeah, okay. Next slide. From our perspective, in our recent study, key clinical predictor of moderate to severe OSA, including age 1 to 5 year, frequent snoring, episode of stop breathing or awakening during sleep, excessive daytime sleepiness, obesity, and adenotonsillar hypertrophy. Those are requires definitive surgery, which is adenotonsillectomy. For my OSA or primary snoring on medication, myofunctional therapy might combine and can taper or tail off medication. For definitive surgery group, the myofunctional therapy might help while waiting for the time to surgery. Next slide. Okay. In craniofacial anomaly who use CPAP, myofunctional therapy might reduce CPAP pressure, which can increase compliance or adherence to CPAP usage. And in another group for obesity, next slide, please. Exercise is important in obesity children to improve sleep disorder breathing and reduce the risk for additional comorbidity related to obesity. But exercise should be high intensity interval training combined with resistance training. That's all I like to add.
And thank you so much, Dr. Nantika, because there is one question that someone asked about the airway for CLIP patient, but we will go for the Q&A. And the next one, I would like to invite Dr. Kumar to share your experience about the pediatric OSA in your practice, or like the worldwide that you involved like in the pediatric OSA world. Yeah, please.
Right. Yeah. So first of all, a major thanks to the ICC team for putting together this webinar. I've been following you guys online for a long period of time, and you've been putting up some amazing topics. And second, Dr. Susana, in this short period of time, you've actually covered a lot of material. You've covered the A to Z's of myofunctional therapy. But just to add on to what you've already talked about and maybe covered actually. So ultimately, when we look at treatment of SRBDs, where our end goal is actually nasal breathing, to promote and to establish and sustain nasal breathing, right? So although not particularly part of the myofunctional therapy, we also look at promoting nasal hygiene to the kids, making sure they irrigate or do nasal lavages on a regular basis, especially if they're prone to more nasal allergies. We are also looking at hypoallergenic diets, anti-inflammatory diets as a part of promoting. And third part is, personally, I've been exploring a bit with oral probiotics, usage of Strep salivarius series. So what we have noticed is the oral probiotics with the Strep salivarius actually create a commensal bacterial load in the mouth. So when you look at bacterial infections that may be secondary bacterial infections in the tonsillitis or adenoid cases, these probiotics seem to be making an impact. And of course, this is all just empirical case reports. I don't see any major studies on it, but this is something that we can start exploring as part of reducing the inflammation, oropharyngeal inflammation. Again, a very, very nice presentation, Dr. Susana.
Thank you. It's supposed for me to comment.
Yeah.
Well, starting with Dr. Kumar. Thank you for the comments. Actually, because I think I'm a lucky one to work with a multidisciplinary team. I do have an internal physician with us, which is somnologist by the European Sleep Research Society. So all our patients, they do blood panels. So yes, we are very aware of the alterations of the microbiome of the oral cavity, but it's for our experience, it's also a negative impact of OSA because of the oxidative stress and or the inflammation that also cause not only because you are talking about a snowball. You don't know where it started. It was only the breathing first. It was the adenoids first. So what you know, it's one brings the other, and the other brings the one. So yeah, but there's a lot of alterations on the microbiome, and there's also a lot of alterations that we see on other biomarkers that vitamin B, for instance, acid folic, vitamin B,
Right.
iron. So there's a
Right,
lot of
right.
alterations that we can see. There are luckily some literature right now, very good literature publishing on that aspects that also give us strength to give supplements to all these patients in order to increase all the and balance all these alterations as well. Yeah, I do agree. And about the comment of the first colleague on the exercise, yeah, because we are talking about better quality of life, so we need to change habits. So yes, control obesity. It's a pandemic situation, I guess. So yes, exercise. It's very important as a quality of life, and we need to change life of our children. Does not matter if they are from Europe or Asia or whatever. So the problems are the same all over. Sedentary quality now it's the rule, but we need to break that. So we need to put exercise in the schools. I think we need to improve food in the schools. We need to improve literacy of the population, also of the physicians, because we are still a few number, even though we are more and more, but we are still a few number on the sleep field, especially on the pediatric field. So yes, we need to work together, of course.
Okay, thank you, Professor Kumar. Next, but last but not least, I'd love to invite Professor Nami for some comments.
First of all, thank you guys for having me. Susana, that was such a beautiful presentation and so complete.
Thank you.
I mean, we know how much beautiful myofunctional therapy comes from Brazil, and you have successfully covered, I think, what they are doing over there. They're so much more advanced than other places in the world. So thank you so much for bringing that. I do have a few slides. However, I know I don't have a lot of time, but I will just share a few things with you guys. This is my daughter, Zoe. I don't recommend taping your lips like this. She was awake just for me to take a photo. I am the founder of Every Circle, and I just posted the link right here to our Facebook group. You guys are also welcome to join us. We have live meetings every Thursday night, free for everybody to watch. I do use a Sono band. You guys talked about me already. I just wanted to bring a little bit of this up. Muhammad Ali, I went to research about him because recently I spoke in Kentucky, and early photo of him, it shows him mouth breathing. We cannot talk about sleep if we don't talk about mouth breathing and craniofacial development. It all starts way back when. And the interesting thing is that some of these photos, yes, he was mouth breathing. We all know they had, he had, what is it called? Guys, help me out. I can't think of the name of it. Not Alzheimer's.
And attention deficit.
Yes, not Alzheimer's disease. What did he have? Parkinson's disease. Thank you.
Parkinson's. Yeah.
Parkinson's disease. I'll show you guys at the end how Parkinson's disease is related. But this video was recently posted on Instagram. Everybody tagged me. The mom is laughing, and she says, I haven't laughed this hard in a while. Look at the extent of what your body will do to keep you alive. This is a child who is choking, who is trying to survive. And of course, as lots of us over here being dental professionals, we can see the high vaulted palate, diastema indicating maybe a lip tie. So I'm just gonna pass it. but we can see all the signs over there. And if more and more of us can recognize these signs, then we can ask for symptoms. And you don't necessarily have to treat anybody over here in the dental field. You get to see patients before they are sick, before they know that there's a problem. Most of them don't have an idea that there's something that can be done. So you're holding very, very important key in your hands, and all I'm asking you to do is just plant seeds. You don't necessarily have to treat these patients. You don't necessarily have to go deep into myofunctional therapy or myofunctional orthodontics. But if you do know how to recognize the signs and the symptoms and knows, and you know exactly who to send these patients to, that would be enough. I am going to pass all of these slides right here. It's talking about, of course, craniofacial development and how it's related to UARS. If we can get these kids in your OSA, if you can get to these kids early before they're 12 years old and their face is already 90% complete, we're going to have better results for their overall health. I am just going to pass through these. You brought a lot of these things that I had over here. The consequences of OSA, of course, we know it's not great. Let me share this quick case with you guys. This is a 5-year-old little boy with ADHD, slight autism, came to me right around COVID, and he wouldn't even stop in front of the computer. Guys, most of you guys know I see all my patients online. And I told the mom, there's no way, you need to see somebody in person. And she said, Renata, there's no way right now. I can't go anywhere. I have to see you. I said, okay, you're my co-therapist. You know, I can see these patients weekly or bi-weekly. However, if you're not doing these exercises at home, it's not going to work. This is after 4 sessions of therapy, about 2 weeks apart. He was taking melatonin every night. He was waking up throughout the night, wet in the bed every night, and taking a whole hour to go to sleep. In 4 sessions, it is completely gone. And as you guys can tell, it looks like a different child. Teachers at school were saying how much more responsive he is, how his cognitive ability has changed. He can actually now sit in front of the computer and complete his exercises. Couple of things about Benny. I have some exercises here. You shared some beautiful exercises. No need for me to do it. Yes, we got to look at everything. It's not only about the muscles. You have these 3 pillars that you have to address. So it's craniofacial development, upper and lower jaw need to be big enough to house the tongue. And then we need the help of our wonderful ENTs to make sure that the airway is free and clear for the air to go through and the patients can breathe well. And of course, then we have to take care of the muscle. If you only address 1 or 2, they will relapse. And then I went further to actually pull up some videos of Muhammad Ali speaking. And then I took some screenshots of his tongue. Oh my goodness, he looked to me like he had a tongue tie. So you can see how he has a tongue thrust. Whenever he's speaking, his tongue is going forward. The size of the tongue is going up. And he has a very hard time elevating his tongue whenever he's speaking. And then I went on to look up to see if maybe he snored. So I looked up this Muhammad Ali snored, and it says some observers noticed signs. Of course, he had neurological decline, he had Parkinson's disease, but he said that his wife could not even sleep in the same room as him because he snored so loudly. And I thought that was so interesting. Here he is, he snored like crazy. And then we see how sleep apnea could be linked to increased Parkinson's disease. But sleep apnea reduces the risk. It doesn't look like he had any treatment whatsoever for his sleep issues. So to go back, if we can catch the sign and the symptoms early, and we can help these children to become, get to their full development where they are supposed to be, all of us working together, because it's not myofunctional therapy alone. We need the help of orthodontics and ENTs. And maybe we can help these kids be healthier longer. Thank you guys for having me.
Thank you so much, Professor Nami, for that very impressive talk. So at this time, I would like to continue to go on to our Q&A session, if that's okay. I know we're running a little late, but just a few more questions for you, Professor Falardo. So the first question is actually asked by Dr. Sabir Hussein, and the question is, have you ever do you think there's a relationship between cleft lip and palate patients and their risk of OSA?
I don't do syndromic patients. Those kind of patients, they are here in Portugal. They are treated 100% at the hospital. I don't work in a hospital. I work in a private clinic. But what I know is from the literature. Yes, they have hypoplasia, maxillary of hypoplasia, so and sometimes endognathia, and they have they develop less the maxillary. So yeah, I could say that they have a negative impact on the volume of the upper airway. But even though I think the literature cannot assume that less volume of the upper airway, it means that this child, it could have obstructive sleep apnea, because we know that are more than one phenotype, sorry. But yes, it's a great risk for a syndromic child with a palatal cleft to have also. Yeah, I would say that. But I don't treat those type of patients.
Thank you for the answer anyways. The second question is from Dr. Ding, and the question is, what if myofunctional therapy was not effective? Is there anything else that you can do for these patients?
What I do when they don't cooperate and I don't have a good results, I don't start with the classic interceptive preventive orthodontics. I do orthopedic functional of the jaws, because I can have both orthopedic corrections and indirect work of the muscles. So I go for that technique.
Okay, thank you so much. And I think the two questions are the only two questions that we have for today. So thank you once again, and I'll return the moderating back to PY.
Yes, thank you. Thank you, Professors, the Falardos. You are very comprehensive. We really learned a lot from your talk, especially in my professionalism is as a surgeon. It's very hard for me, especially for a plastic surgeon, it's very hard for me to know such lost knowledge involving in the pediatric, even in the neonate, even in the growing stage. In our mostly common practice is that obstructive sleep apnea, and we focus on the jaw surgery to try do the MMA to enlarge the posterior pharyngeal wall and airway space only. Actually, this knowledge should be very well documented and earlier be renowned. That probably could reduce the possibility and the prevalences in the future as a kind of a disease in adulthood. So thank you for giving me such a very nice knowledge, and especially we have three important panelists, and thank you prior your friendship to enhance our ICCs. That's why we always so jealous of ICC can have expanded so much to broaden our view to know a lot of important knowledge. Professor Names and Professor Kuma and Professor Susan Wang. Yes, so finally, I would like to invite all our audience of ICC today, and please show you a beautiful smile with
Dr. Jones,
our...
sorry.
Hi, Priya, please.
Because I have
you
one
speak
meeting to share for today. I'm so sorry. I will make it.
Okay, Priya, you have something to speak, right?
Yes.
Okay, sure.
I don't know how I like expand it. I'm sorry. But I have a meeting to share to everyone. It will be like about the dental sleep medicine from the World Dental Sleep Society. And this meeting will join the World Sleep 2025 in Singapore in September this year. So if any dentist would like to join 2025 World Dental Facial Sleep Society Congress, please feel free to join, like to search for the website, and also like go for the worldsleepsociety.org as well. So this is the schedule for the 2 days congress. There's a lot of like world renowned orthodontists and sleep specialists, like from the dentist or ENT or the surgeon as well. And on the September 6th, that will be the workshop. Who interested in the workshop for the racism patient in OSA? So please feel free to join the one-day workshop as well. It's a very interesting schedule. And yeah, that's I would like to share to everyone. So I will repost again in our ICC group. Thank you.
Thank you so much, Briar.
Yeah, so
this is
sorry.
definitely no problems. Yeah, from Chang, we definitely have the one sleep team to join the Singapore sleep the symposium too. All right. I think it's time to show you a smile. Yeah, we are so happy. We have a lot of very strong and a very famous sleep expertise and leading this such a great conferences, the lecture with all of us. So I will count to three. Please give me your beautiful smile. 1, 2, cheers. Thank you so much for all your attendance in this ICC. Let me introduce our next topic in the coming week. That will be presented by Dr. Miyawaki from Japan. The topic is the rhinoplasty, how to deal with the septal rhinoplasty as well. So thank you, Professor Falardo, for your beautiful lecture, and thank you all our beautiful audience today, even you are in the night or in the daytimes. Hope to see you soon, and have a good day and have a good night. See you.
So much.
Thank you.
See you
Bye-bye.
in Singapore. Thank you.
See you in Singapore. Sure. Thank you, Professor Honda. Thank you, Anup. Yeah, thank you, Natalie. Okay, thank you, Dr. Kuma. Thank you, Nine. Thank you so much. Thank you, Susana. Thank you, Prior.
You're welcome. And
Thank you, Junior.
many people like they come to attend, yeah, many Thais and also friends, colleagues. Yeah. Thank you so much, Dr. Susana. Yeah.
Thank
I
you.
saw you did a lot of workshop in myofunctional therapy, or even go to teach the resident in Alberta, right? In Canada.
Yes, I lectured for twice in Alberta last year. Yeah, I might have to go there this year again. But I lectured the Master of Oral Medicine, Periodontology, Orthodontics, and Pediatrics. So myofunctional therapy, it's on me there.
Thank you so much for sharing your presentation and expertise.
Thank you for the lovely invitation. I really appreciated the invitation. Thank you.
Have a good
Thank you
day.
so much.
Bye-bye. Thank
Have
you.
a good day.
Bye.
Bye-bye.
Bye-bye.
Thank you.